Hi everyone, I am Dr. Wafaey Badawy, a senior consultant histopathologist and head of pathology department, AKMICH, KSA. I'll be talking about cord-stromal tumors of the ovary, cord tumor with annular tubules. General background. Cord tumor with annular tubules, SCTAT, is a rare and distinctive ovarian cord-stromal tumor, accounting for approximately 2.3% of cord-stromal tumors. The predominant component of this tumor has intermediate morphologic features between granulosa cell tumors and Sertoli cell tumors, and focal differentiation into either of these tumor types may occur. 1/3 of cases are associated with Peutz-Jegher syndrome, PJS. PJS-associated SCTATs syndromic patients are almost always clinically benign, typically multiple and small, less than 3 cm, associated with germline mutations of STK11. SCTATs unassociated with PJS non-syndromic patients are clinically malignant in at least 20% of cases, often spreading via lymphatics, slightly older than those with PJS, associated with late recurrences, and multiple recurrences may occur over many years. Please note that Peutz-Jegher syndrome, PJS, is an autosomal dominant with a variable penetrance. It shows gastrointestinal hamartomatous polyposis, oral and cutaneous melanin pigmentation, rarely adenoma malignant, minimal deviation adenocarcinoma of the cervix, ovarian cord-stromal tumors or tumorlets with annular tubules, which are almost always benign, increased risk of developing malignancies of breast, ovary, and GIT. In patients with PJS, the tumor has always been an incidental finding at operation or autopsy. Gross appearance. In patients with PJS, tumors are typically multiple and small, less than 3 cm, and are frequently bilateral, 2/3 of patients. In patients without PJS, tumors are typically unilateral, range from 0.5 cm to 33 cm, and have a solid yellow cut surface. Some tumors may show cyst formation, hemorrhage, or necrosis. The malignant potential of SCTAT cannot be reliably predicted by microscopic examination of the primary tumor. Malignant SCTAT seems to spread mainly via the lymphatics, with typical sites of tumor metastasis being the pelvic, para-aortic, and supraclavicular lymph nodes. PET-CT scan before treatment, a black arrow, points to the metastatic tumor in the left portion of the fourth lumbar vertebra. PET-CT scan after treatment. These images show the retroperitoneal tumor fused by several para-aortic lymph nodes. This photo shows a left pelvic lymph node with metastatic tumor deposit. Microscopic features. The tumor is characterized by a mixture of simple and complex ring-shaped tubules that encircle hyalinized basement membrane-like material with a round to oval shape. Simple annular tubules are ring-shaped with peripheral-oriented nuclei around a central hyalinized body, composed of basement membrane material. Most of ring is a nucleocytoplasmic zone. Complex annular tubules are made of intercommunicating rings revolving around multiple hyaline bodies, often calcified. Calcification occurs in more than 50% of PJS-related tumors, which is occasionally extensive. Primary extra-ovarian sex cord tumor with annular tubules. It is extremely rare and unusual incidentally detected microscopic proliferations of sex cord cells in extra-ovarian locations. Small nests of sex cord cells are present in the lamina propria of the fallopian tube fimbriae. At higher power, the nests are well demarcated and composed of regular cells with punched-out spaces containing eosinophilic hyaline material. The nuclear features are bland and occasional nuclei contain grooves. The cell nests are diffusely positive for inhibin. Immunohistochemistry. These tumors show a strong and diffuse immunoreactivity for inhibin, carotinin, WT1, and FOXL2. Differential diagnosis. Gonadoblastoma. These tumors have similar patterns to those of SCTATs, but also contain germ cells such as dysgerminoma. Most patients with gonadoblastoma are phenotypic females with an underlying gonadal disorder and a Y chromosome. Prognosis and therapy. In patients with PJS, sex cord tumor with annular tubules is almost always benign, and prognosis is dictated by other neoplasms seen in this context. In patients without PJS, approximately 20% of SCTATs demonstrate malignant behavior. Unilateral salpingo-oophorectomy and staging are appropriate for young patients with early-stage disease. SCTAT has a greater tendency for lymph node metastasis than other sex cord tumors. Thus, lymph node dissection should be included as part of staging. Recurrences are often late, and cytoreductive surgery is indicated in these cases. These are the references. Thank you.